Welcome to this video entitled Chronic Obstructive Pulmonary Disease. On day 1, Mr. LT, a 68-year-old man, attended his general practitioner's surgery for a routine checkup. He had been diagnosed with asthma 5 years earlier when he had first become short of breath on exertion, although there was no record of any objective testing having been carried out. He had had no history of breathing problems as a child but had been a heavy smoker, smoking approximately 20 cigarettes a day since he was 14 years old, although he had stopped completely 2 years earlier. He lived with his wife in a bungalow and had retired from his job as a factory storekeeper at the age of 60. Since his diagnosis, his condition had deteriorated. He became short of breath after he had walked only 500 meters or climbed one flight of stairs, and he had a chronic cough that produced approximately 1 tablespoon of sputum on a daily basis. Mr. LT had recently had a chest infection that had been successfully treated with a course of antibiotics. His current drug treatment was as listed below. Montelukast 10 mg once daily at night. Salbutamol 100 microgram metered dose inhaler, 2 puffs when required for shortness of breath. Co-amilofruz 5/42 tablets once daily. Beclometasone dipropionate chlorofluorocarbon free, marketed as Clenil, 100 microgram metered dose inhaler, MDI, 2 puffs twice daily. And Simple Linctus, 5 ml when required. His surgery had contacted him to review his condition, prompted by the fact that he had requested 4 salbutamol inhalers every month for the last year and had not used his beclometasone inhaler for several months. Spirometry was performed. His spirometry results were as follows. Forced expiratory volume, FEV1, 0.95 liter. Forced vital capacity, FVC, 1.53 liters. Predicted forced expiratory volume in 1 second, 2.70 liters. Forced expiratory volume in 1 second % predicted 35% forced expiratory volume in 1 second to forced vital capacity ratio 0.62, i.e. 62%. Forced expiratory volume in 1 second post-salbutamol 0.99 liter. In view of his spirometry results, symptoms and history, Mr. LT was diagnosed with chronic obstructive pulmonary disease, abbreviated as COPD. Question 1 reads, what are the clinical similarities and differences between a patient with asthma and one with chronic obstructive pulmonary disease? Both asthma and chronic obstructive pulmonary disease are major chronic obstructive airways diseases that involve underlying airway inflammation. They can present in similar ways, but it is important to distinguish between the two as the pharmacological management is very different. Chronic obstructive pulmonary disease is characterized by airflow limitation that is not fully reversible, is usually progressive, and is associated with an abnormal inflammatory response of the lungs to noxious particles or gases. In chronic obstructive pulmonary disease there is permanent damage to the airways. The narrowed airways are fixed, and so symptoms are chronic, that is persistent. In contrast, episodes of asthma are usually associated with widespread but variable airflow obstruction which is often reversible. In asthma, symptoms come and go and are of varying severity. Many asthmatics are completely asymptomatic for much of the time. Table 12.1 will help to explain the differences between asthma and chronic obstructive pulmonary disease. If the features above are considered alongside Mr. LT's history, it can be seen that he exhibits a picture of chronic obstructive pulmonary disease rather than asthma. He was a heavy smoker and his symptoms started later in life, at the age of 63, after having had no breathing problems as a child. In addition, His condition has deteriorated over the years, with a gradual and persistent increase in breathlessness and now the production of sputum on a daily basis. Pause the video and carefully scrutinize Table 12.1 summarizing clinical features differentiating chronic obstructive pulmonary disease and asthma before advancing to the next slide. Question 2 reads, what factors do you think contributed to Mr. LT's developing chronic obstructive pulmonary disease? Mr. LT has a significant smoking history, and this is most likely to have led to the development of his chronic obstructive pulmonary disease. His occupation should also be explored in more detail, as this too may have contributed to his disease. Chronic obstructive pulmonary disease is overwhelmingly smoking-related. Although it can occur in non-smokers, this is rare. A significant smoking history for chronic obstructive pulmonary disease is 15 to 20 pack years. However, not all smokers are at risk. The popular perception that only 15 to 20% of smokers develop chronic obstructive pulmonary disease is being challenged, and the proportion may actually be as high as 50%. What determines whether people are affected or not is still not understood. The number of cigarettes smoked is important, and people who start smoking early seem more likely to develop chronic obstructive pulmonary disease. It is likely that an individual's genetic makeup is one of the contributory factors. One inherited cause of chronic obstructive pulmonary disease is deficiency of the protective enzyme alpha-antitrypsin. This deficiency renders the individual susceptible to the damaging effects of cigarette smoke. However, it is rare and accounts for less than 1% of all cases of chronic obstructive pulmonary disease. Other identified risk factors are unlikely to cause clinically significant, symptomatic chronic obstructive pulmonary disease on their own, but when combined with smoking in a susceptible individual may compound the risk. These include occupational exposure to dusts and fumes, for example factory workers, such as Mr. LT, or coal miners, recurrent lower respiratory tract infection in childhood, and low birth weight. Question 3 reads, a person's smoking history can be quantified by calculating their pack years. What is Mr. LT's smoking history in pack years? Mr. LT's pack year history is 52 years. Lifetime smoking exposure is quantified in pack years, where 1 pack year is 20 cigarettes smoked per day for 1 year. Therefore, number of pack years is equal to number of cigarettes smoked per day multiplied by the number of years smoked, all divided by 20, that is the number of cigarettes in a pack. Mr. LT's pack year history is 20 divided by 20 all multiplied by 52, started at age 14 and stopped at 66 years, which adds up to 52 pack years. Quantification of pack years smoked is important in clinical care, where the degree of tobacco exposure is closely correlated to the risk of disease. There is a strong dose-response relationship between the number of pack years smoked and the risk, severity and mortality associated with chronic obstructive pulmonary disease. Question 4 reads, what do Mr. LT's spirometry results tell us about his disease? Mr. LT has a reduced forced expiratory volume in 1 second, 35% of predicted normal that is greater than 80%, and a reduced forced expiratory volume in 1 second to forced vital capacity ratio, 62%. The results confirm a diagnosis of obstructive pulmonary disease. The fact that there is very little reversibility following salbutamol therapy makes the diagnosis of chronic obstructive pulmonary disease most likely. Spirometry is performed by asking the patient to exhale as hard and as quickly as possible after a full deep inspiration until there is no breath left in the lungs. Two measurements are of particular interest: forced expiratory volume in the first second and forced vital capacity, FVC. The forced expiratory volume in 1 second is the volume of air expelled in the first second of a forced expiration starting from full inspiration, and the forced vital capacity is the maximum volume of air in liters that can be forcibly and rapidly exhaled following a maximum inspiration. Individual performance is compared with population norms standardized for height, age and race, and is expressed as a percentage of the predicted value. In an obstructive lung disease such as chronic obstructive pulmonary disease in which the airways are narrowed, forced expiratory volume in 1 second is predominantly reduced and the forced vital capacity is normal or only slightly reduced, making the forced expiratory volume in 1 second to forced vital capacity ratio lower than normal, i.e. a ratio of less than 70%. Forced expiratory volume in 1 second is preferred to peak expiratory flow (PEF), as a measure of airflow in patients with chronic obstructive pulmonary disease because it more reliably measures the extent of airway obstruction. Categorization of the severity of chronic obstructive pulmonary disease varies between countries and clinical guidelines. NICE has graded the severity of airflow limitation in chronic obstructive pulmonary disease as follows. Mild corresponds to a forced expiratory volume in 1 second 50 to 80% of predicted value. Moderate corresponds to a forced expiratory volume in 1 second 30 to 49% of predicted value. Severe corresponds to a forced expiratory volume in 1 second less than 30% of predicted value. Using these definitions, Mr. LT can be classed as having moderate chronic obstructive pulmonary disease. However, the severity of a patient's disease should not be based simply on their airflow limitation. Assessment of chronic obstructive pulmonary disease severity should consider the level of their symptoms, the degree to which the symptoms affect daily life, the severity of the spirometric abnormality, and the presence of complications such as respiratory failure, cor pulmonale, weight loss, and arterial hypoxemia. Mr. LT's airways showed little reversibility after a dose of salbutamol. Measurement of the degree of reversibility using bronchodilators or corticosteroids has traditionally been used to confirm the diagnosis of chronic obstructive pulmonary disease, and in particular to try to separate chronic obstructive pulmonary disease patients from those with asthma. The recent NICE Chronic Obstructive Pulmonary Disease Guideline recommends against the use of routine spirometric reversibility testing as part of the diagnostic process, as the two diseases can usually be distinguished on the basis of history and examination. If diagnostic doubt remains, or both chronic obstructive pulmonary disease and asthma are present, a large that is greater than 400 ml response to bronchodilators should be used to help identify asthma. Spirometric staging is therefore a pragmatic approach to guide care, and should only be regarded as an educational tool and a general indication to the initial approach to patient management. Question 5 reads, in light of Mr. LT's revised diagnosis, would you recommend any changes to his therapy? The correct response is, yes. Mr. LT has been treated as an asthmatic and his medicines need to be reviewed in order to manage his chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is not synonymous with asthma and should be approached and treated differently. The pharmacological management of a patient with asthma is very different from that of one with chronic obstructive pulmonary disease, although similar drugs may be used for both. Asthma should be regarded as a separate condition from chronic obstructive pulmonary disease, with different causes, different cellular mechanisms and different responses to treatments. Comparison of tissues sampled from the airways of non-smoking asthmatics with reversible disease and smokers with chronic obstructive pulmonary disease, in whom there is fixed airflow obstruction, demonstrates that although both conditions are associated with chronic inflammation, their pathologies are distinct. In chronic obstructive pulmonary disease, the abnormal inflammatory response involves macrophages, neutrophils and CD8+ T cells and results in structural changes and fixed narrowing of the airways, with destruction of the lung parenchyma. In the bronchial wall of patients with asthma, there is frequently a prominent eosinophil infiltrate which is readily damped down by corticosteroids. Neutrophils are relatively insensitive to corticosteroids. The airway lumen in asthma patients is normally maintained, although it may be plugged with mucus. In contrast, in chronic obstructive pulmonary disease, the bronchiole wall is considerably thickened with extensive fibrosis and an inflammatory infiltrate, and the lumen may be collapsed, with reduced alveolar wall attachments. The latter normally hold the walls of the small airways open. Not surprisingly, chronic obstructive pulmonary disease patients do not respond as well to treatments as do asthmatics, and this frequently leads to unnecessary escalation of treatment while other important management issues are overlooked. It looks as if this has happened in Mr. LT's case. Now his correct diagnosis has been established, he can be given the correct medication regimen, more realistic expectations about the outcomes of treatment, advice regarding his lifestyle and more appropriate and holistic management. The following changes should be made to his therapy. A. Montelukast, a leukotriene receptor antagonist, is not licensed for the management of chronic obstructive pulmonary disease. It has no proven role in the management of chronic obstructive pulmonary disease and should be stopped. B. Beclometasone dipropionate chlorofluorocarbon-free or any inhaled corticosteroid is not licensed for patients with chronic obstructive pulmonary disease, unless prescribed in combination with a long-acting beta-2 agonist. Managing chronic obstructive pulmonary disease as asthma may lead to overuse of steroids. Inhaled steroids are indicated for nearly all asthmatics, but only for chronic obstructive pulmonary disease patients with moderate or severely reduced forced expiratory volume in 1 second, defined as forced expiratory volume in 1 second less than 50%, with frequent exacerbations. Mr. LT had not been using his beclometasone as he perceived no benefit from it. As he appears not to be experiencing frequent exacerbations, it could be removed from his repeat prescription at present. However, it is important to question him carefully about his exacerbation history. More than half of chronic obstructive pulmonary disease patients fail to report life-threatening exacerbations. In addition, his currently prescribed dose of inhaled beclometasone would not be high enough to manage his chronic obstructive pulmonary disease and reduce the risk of exacerbations. The benefits of inhaled corticosteroids in patients with chronic obstructive pulmonary disease have only been observed using high-range dosing, e.g. fluticasone 1000 micrograms daily or budesonide 800 micrograms daily. An inhaled corticosteroid may be an appropriate option for Mr. LT later in the course of his disease. C. Bronchodilators may be underused if patients with chronic obstructive pulmonary disease are managed as asthmatics. In symptomatic patients, the cornerstone of management of breathlessness in chronic obstructive pulmonary disease is inhaled bronchodilation. Although they do not significantly improve lung function, that is the forced expiratory volume in 1 second, bronchodilators improve breathlessness, exercise capacity and quality of life. Short-acting bronchodilators such as salbutamol, terbutaline or ipratropium are given for relief of intermittent breathlessness and can be used regularly throughout the day, often at higher than licensed doses. This level of bronchodilator use in patients with asthma would be regarded as a sign that the asthma is poorly controlled and the patient's treatment may need optimizing. Indeed, the surgery had asked Mr. LT to make an appointment for a review of his asthma, as he was overusing his salbutamol inhaler for each month. Furthermore, in contrast to asthma, anticholinergic drugs such as ipratropium are as effective as or more effective than beta-2 agonists and are thus indicated in the management of stable chronic obstructive pulmonary disease. It would be logical to prescribe regular ipratropium therapy for Mr. LT, with salbutamol added on a, when required, basis to supplement this if necessary. D. There may also be underuse of non-pharmacological methods to manage Mr. LT's condition, especially pulmonary rehabilitation and vaccination. 1. Exercise programs are beneficial to chronic obstructive pulmonary disease patients at all stages of the disease and can improve quality of life, sexual function and pulmonary function tests, and also reduce oxygen requirements if regular oxygen therapy is required. Mr. LT should be referred to a local pulmonary rehabilitation class. 2. Chronic obstructive pulmonary disease patients are at increased risk of mortality and morbidity from respiratory infections. It is important that Mr. LT receive pneumococcal and annual influenza vaccines. E. Advice about nutrition may be appropriate for Mr. LT. Weight loss is common in people with advanced chronic obstructive pulmonary disease, and being underweight is clearly associated with a higher risk of dying. People with chronic obstructive pulmonary disease work harder to breathe and burn more calories at rest than individuals without chronic obstructive pulmonary disease, making nutritional supplementation an important non-pharmacologic treatment modality. However, obesity increases breathlessness, and such patients should be encouraged to lose weight. Dietary advice can help to maintain an ideal weight and is most effective when combined with exercise training that builds muscle mass. Question 6 reads, how would you decide if an intervention to his therapy had helped? Assessment of effectiveness should be based on both objective and subjective measures. The effectiveness of bronchodilator therapy should be assessed using a variety of factors, including lung function, improvement in symptoms and exercise capacity. Asking Mr. LT some simple questions can help to determine whether a treatment has helped. For example, A. How often does he tend to use his salbutamol inhaler? An increase in use indicates poor symptom control. B. Does he think his treatment has helped in any way? 1. Has it made a difference to his life? 2. Is his breathing easier? 3. Can he do things now that he was unable to do before, or the same things but faster? 4. Can he do the same things as before but is now less breathless doing them? 5. Has his sleep improved? Recording his Medical Research Council (MRC) dyspnea scale score, see Table 12.2, is a useful measure of his exercise tolerance. Also, checking how many exacerbations he has had during the last year as a minimum, or longer if recorded or he can remember, can help to assess whether drugs such as long-acting bronchodilators or inhaled corticosteroids have helped. Pause the video and carefully scrutinize Table 12.2 summarizing MRC dyspnea scale before advancing to the next slide. Mr. LT was started on ipratropium 20 micrograms, 2 puffs 4 times a day via a metered dose inhaler with a spacer device. Mr. LT questioned whether this would be better given to him via a nebulizer. Question 7 reads, many chronic obstructive pulmonary disease patients ask for home nebulizers. What is the place of nebulizers in the management of chronic obstructive pulmonary disease? In the majority of cases, a metered-dose inhaler, plus spacer, is either as good as or better than a nebulizer. NICE guidance restricts the prescribing of nebulizers, and only recommends consideration of a nebulizer for patients with distressing or disabling breathlessness despite maximal therapy using inhalers. Most patients achieve maximum possible bronchodilation with drugs administered by conventional inhalers. This statement is supported by clinical trials, as there is no evidence to suggest superiority of nebulized therapy over the use of a metered-dose inhaler with a spacer. However, nebulizer therapy is popular with patients because it requires no effort, and many patients derive subjective benefit from the moistening or cooling effects of the aerosol generated by the nebulizer. Often this can be achieved by recommending that the patient uses a fan. Nebulizers also have a mystique for patients and their families, which ensures that their reputation often outweighs the reality. Compressors to drive nebulizers are relatively cheap, but the drug costs are high and patients may experience more systemic side effects. Other disadvantages are listed in Table 12.3. For all these reasons, patients should be encouraged to use spacer devices with metered-dose inhalers before considering the use of nebulizers. Certainly, a formal assessment should be made before long-term, regular nebulizer therapy is initiated. The assessment should confirm that one or more of the following occurs. A reduction in symptoms. B. An increase in the ability to undertake activities of daily living. C. An increase in exercise capacity. D. An improvement in lung function. Nebulized therapy should generally be reserved for patients with severe chronic obstructive pulmonary disease. It is likely that such patients will have some contact with a specialist respiratory team who are usually best placed to arrange appropriate supply, proper use and maintenance of the device. Pause the video and carefully scrutinize Table 12.3 advantages and disadvantages of nebulizer therapy before advancing to the next slide. On day 30, Mr. LT struggled to the surgery for his follow-up appointment. He admitted to having felt unwell for the last 5 days, with increasing dyspnea and wheeze. He had a cough productive of yellow-green sputum and swelling of the ankles. His wife said he had become too breathless to speak or eat, and today had been delirious. He could not walk further than from the chair to the toilet. His general practitioner referred him to the hospital and he was admitted to a medical ward via accident and emergency. On examination he was centrally cyanosed. His chest was initially silent, but after one dose of salbutamol 5 mg by nebulization coarse crackles could be heard at the right base. He was diagnosed as having a right basal pneumonia with deterioration of his chronic obstructive pulmonary disease. An arterial blood sample was sent for analysis of blood gases, with the patient breathing 35% oxygen by face mask. Mr. LT's blood gas results were blood pH 7.26. The reference range is 7.32 to 7.42. PaO2 10.23 kilopascals. The reference range is 12 to 15 kilopascals. Standard bicarbonate 29.2 millimoles per liter. The reference range is 21 to 25 millimoles per liter. PaCO2 10.21 kilopascals. The reference range is 4.5 to 6.1 kilopascals. The following drug therapy was written up. Intravenous IV aminophylline 1 gram in 1 liter, sodium chloride 0.9% to be given by continuous infusion over 24 hours. Salbutamol 5 mg every 4 hours via a nebulizer. Ipratropium bromide 500 micrograms every 4 hours via a nebulizer. Hydrocortisone 100 mg IV every 6 hours. Ceftriaxone 2 grams IV once daily. Serum biochemistry and hematology results were as follows. Sodium 141 millimoles per liter. The reference range is 137 to 150 millimoles per liter. Hemoglobin 17.7 grams per deciliter. The reference range is 14 to 18 grams per deciliter. Potassium 5.2 millimoles per liter. The reference range is 3.5 to 5 millimoles per liter. White blood cells WBC 18.1 times 10 power 9 per liter. The reference range is 4 to 11 times 10 power 9 per liter. Urea 5.4 millimoles per liter. The reference range is 2.5 to 6.6 millimoles per liter. Mr. LT was thought to be fluid depleted and was prescribed 1 unit of polygaline IV infusion to be given over 30 minutes, followed by 2 liters of glucose saline infusion, each liter to be given over 8 hours. Question 8 reads, what do Mr. LT's history, symptoms and blood gases indicate about his respiratory disease? Mr. LT's rapidly increasing dyspnea and general disability over the past few days suggest that his respiratory condition has deteriorated because of an acute event. His productive cough and discolored sputum make a chest infection the most likely cause. His symptoms of cyanosis show that his lungs are failing to provide efficient gaseous exchange and that he is in respiratory failure. This can be confirmed by the blood gas results. Mr. LT was given 35% oxygen on admission, before the first blood gases were measured. Usually a lower oxygen concentration, that is 24%, is used, in order to avoid inhibiting the hypoxic ventilatory drive often present in chronic obstructive pulmonary disease patients. The high oxygen concentration administered to Mr. LT initially may have contributed to his carbon dioxide retention. There is little point raising the PaO2 greater than 8 to 9 kilopascals, as the increase in oxygen saturation achieved will not be worthwhile, from about 90% to 95%, when balanced against the risk of raising the PaCO2. Mr. LT's PaCO2 is markedly raised, which means that he has type 2, that is ventilatory, failure, where alveolar ventilation is insufficient to prevent a rise in PaCO2. This is in contrast to type 1, that is oxygenation failure, where the PaO2 falls below 8 kilopascals. But a rise in PaCO2 is counteracted by increased respiratory muscle drive. The accumulation of carbon dioxide leads to respiratory acidosis with a low blood pH. When this becomes a chronic condition, as in Mr. LT's case, the kidneys compensate by excreting more hydrogen ions into the urine at the expense of potassium ions and returning more bicarbonate ions to the circulation, thereby causing a rise in plasma bicarbonate. Question 9 reads, what are the immediate therapeutic priorities for Mr. LT? The immediate therapeutic aims are a. Correction of acute respiratory failure, and b. Treatment of infection. Question 10 reads, outline the key elements of a pharmaceutical care plan for Mr. LT. The pharmaceutical care plan for Mr. LT should include the following. A. Advise medical staff on choice of antibiotics and formulary restrictions, dosage regimens of bronchodilators, therapeutic drug monitoring of aminophylline or theophylline, treatment options for cor pulmonale. B. Advise nursing staff on administration of IV antibiotics, administration of nebulized bronchodilators. C. Monitor Mr. LT's therapy for efficacy and toxicity of antibiotics, bronchodilators and diuretics. D. Monitor theophylline serum concentration measurements. E. Review therapy prescribed for his acute condition, assessing the suitability of each drug for long-term maintenance therapy. F. Assess the suitability of the patient's own drugs (PODs) belonging to Mr. LT for use in hospital, and remove those no longer appropriate, after discussion with the patient or his relatives. G. Counsel Mr. LT on the use of his medication, with particular emphasis on his inhaled therapy. H. Ensure that any of Mr. LT's own drugs used during his stay are still current and suitably labeled before discharge, and check that any medicines at home are still appropriate for his use. I. Consider issuing a patient medication record to the patient, his carer, his general practitioner and/or a community pharmacist of his choice. J. Consider non-drug factors that may be important, e.g., if he had still been smoking, would referral to a smoking cessation clinic have been appropriate? K. Consider whether the patient is suitable for long-term oxygen therapy. L. Consider referral to a local pulmonary rehabilitation program. M. Consider referral to a dietitian. Question 11 reads, do you agree with the choice of agents to treat Mr. LT's respiratory condition? Comment on the doses prescribed. A. Antibiotic therapy. An antibiotic with a narrower spectrum of activity would have been more appropriate. The Department of Health recommends prudent antibiotic prescribing to reduce the use of broad-spectrum antibiotics, such as ceftriaxone, to help prevent and control Clostridioides difficile infection. Many clinical areas have introduced a narrow-spectrum antibiotic policy. The cause of Mr. LT's acute respiratory failure is infection, so treatment with an appropriate antibiotic is very important. Sputum and blood samples should be sent for culture and sensitivity, but the most likely causative organisms are Haemophilus influenza and Streptococcus pneumoniae. Amoxicillin, erythromycin, tetracycline or trimethoprim would therefore usually be adequate. However, up to 10% of Haemophilus influenza strains are now resistant to amoxicillin, and, bearing in mind the severity of Mr. LT's condition, the use of these agents is probably not appropriate without a sensitivity report. Co-amoxiclav at a dose of 1.2 grams 8 hourly would have been a more suitable alternative for Mr. LT, as it is effective against penicillinase-producing bacteria that are resistant to amoxicillin. In a patient with a severe community-acquired pneumonia such as Mr. Lieutenant, the British Thoracic Society (BTS) guidelines recommend a combination of a broad-spectrum beta-lactamase antibiotic such as co-amoxiclav, cefuroxime or ceftriaxone, together with a macrolide antibiotic such as erythromycin or clarithromycin. This would then cover for Legionnaire's disease and other atypical organisms. Use of a macrolide would also be appropriate if Mr. LT had recently returned from a foreign holiday. Additionally, penicillin-resistant pneumococci are becoming much more common, particularly in certain parts of Europe, South Africa and South America, and recent travel to these areas could justify the use of ceftriaxone. A urine test is available for pneumococcal and Legionella antigens, which could have confirmed or eliminated the presence of these organisms in 15 minutes. B. Bronchodilator therapy. It was appropriate to prescribe 3 bronchodilators for Mr. LT, but a loading dose of aminophylline should have been given. Much of the airways obstruction of chronic obstructive pulmonary disease is not reversible by bronchodilator therapy as it is caused by mucus plugs and bronchiolar inflammation. Airway obstruction leads to excess air being trapped in the lungs during exhalation. This is a primary cause of breathlessness and often restricts a patient's ability to perform daily activities. Although bronchodilators cannot reverse the effects of chronic obstructive pulmonary disease, their efficacy as a treatment lies in their ability to act on the airway smooth muscle, widening the airways and reducing dynamic hyperinflation during exercise and at rest. Although only a small objective improvement can be measured, this may be significant in someone with extremely poor respiratory function. The mode of action of beta-2 agonists is to increase smooth muscle cell cyclic adenosine monophosphate (AMP) levels and stabilize mast cells. Salbutamol or terbutaline in nebulized form are routinely prescribed in hospital for patients with an acute severe chronic obstructive pulmonary disease exacerbation, even though, as discussed earlier, a metered dose inhaler and spacer may be as effective. The decision as to what method to use will depend on the need for expedient treatment and the availability of staff to aid the administration. The dose equivalent to 5 mg of salbutamol delivered by nebulizer is 8 to 10 puffs of 100 micrograms salbutamol by metered dose inhaler and spacer. The maximum recommended dose for nebulized salbutamol is 5 mg 4 times daily. But because in severe airways obstruction the quantity of drug reaching the site of action may be limited, a smaller dose given more frequently can be more successful. NICE guidance on chronic obstructive pulmonary disease points out that the dose-response curve for salbutamol given by nebulizer in largely or completely irreversible chronic obstructive pulmonary disease is almost flat. The response is slower in chronic obstructive pulmonary disease than in asthma, and there is little benefit in giving doses larger than 1 mg salbutamol. The mode of delivery should be changed to a metered dose inhaler with a spacer device or a dry powder inhaler within 24 hours of the initial dose of nebulized bronchodilator, unless the patient remains severely ill. Ipratropium bromide is an anticholinergic agent which blocks the cholinergic reflex that causes bronchospasm. It is particularly useful in combination with beta-2 agonists in chronic obstructive pulmonary disease patients, producing slightly greater bronchodilation than either agent alone. The onset of action of ipratropium is slower than for the short-acting beta-2 agonists and the duration of action is longer. The peak effect is noted between 1 and 2 hours after the dose. The maximum recommended dose of nebulized ipratropium is 500 micrograms 4 times daily, and in view of its longer duration of action than salbutamol, there is unlikely to be any advantage in giving it more frequently than this. Rationalizing the use of ipratropium nebules in this way can also result in a significant cost saving. In addition to causing relaxation of bronchial smooth muscle, there is some evidence that theophylline may have other beneficial actions in chronic obstructive pulmonary disease. It is thought to act as a respiratory stimulant, reduce respiratory muscle fatigue, improve right ventricular performance and increase mucociliary clearance. Another advantage is that, unlike the other two bronchodilators in the regimen, IV aminophylline does not depend on penetration of the obstructed bronchioles to exert its effect. However, the use of a methylxanthine drug such as aminophylline as an additional bronchodilator during an acute exacerbation is not well supported by evidence. A recent systematic review on the use of methylxanthines in acute chronic obstructive pulmonary disease exacerbations found no evidence to support their routine use, particularly for clinical situations involving mild to moderate and/or non-acidotic acute exacerbations. Although clinical evidence for the benefits of methylxanthines is inconclusive, IV aminophylline should be added to the bronchodilator therapy of a chronic obstructive pulmonary disease patient such as Mr. LT, who has severe acute respiratory failure. In such circumstances, the benefits of respiratory stimulation and any effect on respiratory muscles may be more important than bronchodilation per se. However, the aminophylline dosage regimen prescribed for Mr. LT was not optimal. He was given an arbitrary maintenance dose of 42 mg per hour. As he was not taking oral theophylline or aminophylline before admission, he should have received a loading dose in order to achieve a therapeutic concentration rapidly. The normal half-life of theophylline in adults is 8 hours, and so steady state without a loading dose can only be achieved after approximately 32 hours. With a suitable loading dose of 5 mg per kilogram, or worked out by pharmacokinetic calculation, administered over 20 to 30 minutes, a therapeutic concentration would have been achieved far more rapidly. After loading is completed, the maintenance dose should be started. Ideally, the maintenance dose should be determined using pharmacokinetic calculation, which takes into account those factors that affect theophylline clearance, such as smoking history. The plasma concentration of theophylline should then be monitored to maintain therapeutic levels between 10 and 20 mg per liter. As no loading dose was given, the earliest time usefully to measure Mr. LT's plasma concentration is 12 to 20 hours after starting the infusion, which represents twice the normal half-life. Even at this time, the concentration can only be a guide as to whether the dose is too high or too low, as steady state will not have been reached. If a loading dose had been given, it would have been worth checking the level after 6 to 8 hours and adjusting the dose up or down as necessary. C. Corticosteroid therapy. The use of IV and oral corticosteroids in the short term in Mr. LT's condition is normal practice and makes theoretical sense, as eosinophilic inflammation is thought to play a significant part in airways obstruction during an acute exacerbation. Steroids do seem to improve several outcomes during an acute chronic obstructive pulmonary disease exacerbation, including hastening resolution and reducing the likelihood of relapse. Even though the optimal dose and duration of therapy have not been established, a 7 to 14-day course of prednisolone 30 mg daily would be appropriate for most patients. The dose of hydrocortisone prescribed for Mr. LT is one that is commonly used and should be reduced as his condition improves, with a change to prednisolone as soon as he can take oral medication. Question 12 reads: what would you tell a nurse who had never administered salbutamol or ipratropium by nebulizer before? I would emphasize the following important points. A. Volume of nebulized solution. Nebulizers have a dead volume of usually just under 1 ml, which will not be available to the patient, so the larger the fill volume, the greater the fraction of drug released. However, increasing the volume increases the time for nebulization. In hospital, a volume of 4 to 5 ml is an acceptable compromise, producing an administration time of 15 to 30 minutes. As Mr. LT is written up for 5 mg salbutamol, 2.5 ml nebule, and 500 micrograms ipratropium, 2 ml nebule, every 4 hours, it is convenient to mix the two in the nebulizer, making a total volume of 4.5 ml. This is common practice on wards, although the stability of the two solutions combined has not been fully evaluated. Unpublished work carried out on the stability of the mixture using the preserved formulations suggested that they would be compatible when mixed in this way, but both formulations are now preservative-free, which could theoretically affect the results. Where the volume of fluid is insufficient and dilution is required, sodium chloride 0.9% should be used, as hypertonic solutions may provoke bronchospasm. A combination product, Combivon Nebules, is available, which contains ipratropium bromide 500 micrograms plus salbutamol 2.5 mg in 2.5 ml saline. This may be used as an alternative where the dose of each drug prescribed is equivalent, bearing in mind the above considerations. However, the need for these drugs to be prescribed together should be considered carefully in each case, particularly in long-term maintenance therapy. Combivon metered dose inhaler has been discontinued as the company was unable to reformulate it as chlorofluorocarbon-free. B. Driving gas. The driving gas for nebulizers may be air or oxygen at a rate of 6 to 8 liters per minute. In patients with chronic obstructive pulmonary disease who may have low oxygen tolerability, the driving gas should be air using a nebulizer compressor. If supplementary oxygen is required, a safe approach would be to use air as the driving gas for administration of bronchodilators and to administer oxygen via a nasal cannula. On day 32, inpatient day 2, Mr. LT's condition started to improve, with little breathlessness and wheezing at rest, minimal coughing and sputum production, and no cyanosis. Following continuous administration of 28% oxygen, his arterial oxygen concentration was 12 kilopascals, so the oxygen prescription was changed to, when required. He was apyrexial and only scattered rhonchi could now be heard in both lungs. A repeat chest X-ray still showed some increased shadowing at the right base. Aminophylline was continued by the IV route, with the infusion rate unchanged. The patient was noted to be shaking. Question 13 reads, could Mr. LT's drug therapy be causing his tremor? The correct response is, yes. Salbutamol is known to cause a fine tremor of skeletal muscle, along with other manifestations of sympathetic stimulation such as an increase in heart rate and peripheral vasodilation. These effects occur particularly when large doses are inhaled. Aminophylline can also cause tremor, but in most cases only at plasma concentrations above the therapeutic range. On day 33, inpatient day 3, on the ward round, Mr. LT's salbutamol dosage was reduced as suggested to 2.5 mg by nebulizer every 6 hours. His serum theophylline concentration was reported to the ward as 15.8 mg per liter. The reference range is 10 to 20 mg per liter. His IV aminophylline therapy was stopped and oral theophylline was prescribed. Question 14 reads, how would you recommend IV aminophylline be converted to oral theophylline? My recommendations would be, A. Convert the hourly infusion rate of aminophylline to the total amount administered in 24 hours by multiplying the hourly dose by 24. B. In order to calculate the equivalent theophylline dose, multiply this total aminophylline dose by 0.8, which is the salt correction factor. C. Divide this total amount by the dosing interval for oral administration, e.g. by 2 for twice daily dosing. It is assumed that the oral product is completely absorbed, i.e. the bioavailability is 100%. D. A suitable theophylline dosing regimen could be uniphylline continues 400 mg twice daily. Mr. LT has received 1008 mg, dose 42 mg per hour, of aminophylline, a combination of theophylline and ethylene diamine, in 24 hours. 1008 mg aminophylline is equivalent to 1008 multiplied by 0.8, which is the salt factor. This is equal to 806 mg theophylline daily. When calculating a convenient dose for Mr. LT, it is advisable to round the dose downwards, because in some patients theophylline exhibits zero-order kinetics in the upper half of the therapeutic range, and a small increase in dose may produce a large increase in plasma concentration. As his reported plasma concentration was in the middle of the therapeutic range, conversion to an equivalent oral regimen is appropriate. The infusion has been running for over 48 hours at a constant rate, so steady state has been achieved, and as it is a continuous IV infusion, the sampling time is not critical. As always, when interpreting drug level data, the result should be judged in the light of the patient's clinical response. If the current dose had been ineffective or toxicity had occurred, a change of dose should have been considered even if the reported level was in the therapeutic range. When changing a patient's therapy from IV aminophylline to oral therapy with either theophylline or aminophylline, the bioavailability and the salt equivalence should be considered. The salt factor for aminophylline is approximately 0.8, i.e., the amount of a labeled dose of aminophylline that comprises theophylline is about 80%. It is often not possible to achieve a dose that is exactly the same when converting from IV to oral therapy. The nearest practical dose should therefore be used. This is rarely a problem, as pharmacokinetic and drug assay variability means that measured theophylline levels are often not the same as predicted levels anyway. When treatment is changed from IV to oral therapy, the maintenance infusion should be stopped and oral therapy should be begun immediately. On day 35, inpatient day 5, Mr. LT was now on the following regimen: prednisolone 30 mg once daily every morning, theophylline 400 mg slow-release tablets, 1 tablet twice daily, salbutamol nebulizer solution, 2.5 mg nebule 4 times daily via a nebulizer, amoxicillin 500 mg 3 times daily for 7 days, salbutamol 100 microgram metered dose inhaler, 2 puffs when required, tiotropium 18 micrograms once daily via a handihaler device, ipratropium nebulizer solution, 500 microgram nebule 4 times daily via a nebulizer. Question 15 reads, is the prescribing of a long-acting anticholinergic appropriate for Mr. LT? Is there any therapy that should be discontinued? The correct response is, yes, a long-acting anticholinergic should be started to try to improve his symptoms. It may also help to reduce his risk of exacerbations. It would be appropriate to substitute tiotropium for ipratropium at this stage while continuing, when required, salbutamol. In patients with persistent breathlessness, regular bronchodilation with a long-acting anticholinergic agent such as tiotropium, or a long-acting beta-2 agonist, can improve lung function, reduce dynamic hyperinflation of the lungs, and hence reduce the work of breathing and improve exercise capacity. Long-acting bronchodilators also reduce the frequency of exacerbation rates in patients with chronic obstructive pulmonary disease, and NICE guidance recommends that they should be used in patients who have 2 or more exacerbations per year. Tiotropium is more effective than ipratropium in chronic obstructive pulmonary disease. It has been shown to reduce exacerbations and related hospitalizations compared to placebo and ipratropium therapy. It also improves health-related quality of life and symptom scores in patients with moderate and severe disease, and may slow the decline in lung function. Further randomized controlled trials CTs are required to assess the effectiveness of tiotropium in mild and very severe chronic obstructive pulmonary disease. Until then, ipratropium continues to be recommended as first-line treatment for patients with chronic obstructive pulmonary disease with intermittent symptoms. The UPLIFT, an abbreviation for Understanding Potential Long-Term Impacts on Function with Tiotropium, study was a 4-year prospective double-blind RCT, N equals 5,993, which compared tiotropium with placebo in patients with chronic obstructive pulmonary disease. It did not show a benefit in its primary outcome of reducing the rate of lung function decline, as measured by forced expiratory volume in 1 second. However, there was a small reduction in exacerbations, about 12 fewer for every 100 patients per year, but no reduction in exacerbations leading to hospitalization, total number of exacerbations or number of days in hospital. A recent meta-analysis and observational study has signaled the possibility of an increased risk of cardiovascular events with inhaled anticholinergics in people with chronic obstructive pulmonary disease. Uplift provides limited reassurance about these cardiovascular risk signals for tiotropium. In the Uplift study there were no statistically significant differences in the risk of myocardial infarction or stroke compared with placebo. However, the trial was not designed to look at any cardiovascular endpoints, so there may have been differences in how these outcomes were reported. Uncertainty still exists regarding the cardiovascular safety of inhaled anticholinergics in people with chronic obstructive pulmonary disease. A long-term RCT specifically designed to look at cardiovascular outcomes is necessary to confirm and quantify any possible increased cardiovascular risk. INSPIRE, a study comparing the long-acting anticholinergic bronchodilator tiotropium against a combination of the long-acting beta-2 agonist salmeterol and inhaled steroid fluticasone in 1323 patients, found little to choose between the two treatments. However, they did appear to work in different ways, thus suggesting there may be benefit from combining all three. Indeed, the combination of salmeterol, fluticasone propionate and tiotropium are commonly used treatments in chronic obstructive pulmonary disease, but there are few data on their effectiveness when used together. Adequately powered long-term studies of the benefits of triple therapy on exacerbation rates and other clinical endpoints are now needed to justify this approach in clinical practice. The co-administration of tiotropium bromide with other anticholinergic-containing drugs has not been studied and is therefore not recommended. Both tiotropium and ipratropium are antagonists of three muscarinic receptor subtypes, i.e. M1, M2 and M3. Blockade of these receptors in the smooth muscle of the airways inhibits the activity of acetylcholine, which reduces cyclic guanosine monophosphate levels to yield bronchodilation. Tiotropium's differences in receptor association and dissociation rates distinguish its pharmacology from that of ipratropium. Tiotropium dissociates most rapidly from the M2 receptors. Stimulation of the M2 receptors reduces acetylcholine release. Blockade may result in further bronchoconstriction. Tiotropium's long duration of action is likely to be a result of its slower dissociation from the M1 and M3 receptors. This selective pharmacology at M2 is theoretically lost when both agents are used together. Furthermore, there may potentially be an increase in anticholinergic adverse effects from the administration of both agents, e.g. dry mouth, blurred vision. On day 37, inpatient day 7, because a degree of cor pulmonale was present, with ankle edema and ECG electrocardiogram abnormalities, large P waves and right axis deviation, Mr. LT was started on furosemide 40 mg, 1 tablet each morning. His oxygen saturations were noted to be 91% on air. Question 16 reads: Is this treatment appropriate for Mr. LT's cor pulmonale? What alternative therapies could be prescribed? The treatment is appropriate provided Mr. LT's serum potassium level is checked first. Treatment of the respiratory failure, supplementation with oxygen, and diuretic therapy are the mainstays of the treatment of cor pulmonale. Other drugs such as vasodilators may be helpful as second-line agents. Cor pulmonale is fluid retention and heart failure associated with diseases of the lung. It is initiated by pulmonary artery hypertension. which produces a high afterload and hence right ventricular hypertrophy. There is no intrinsic abnormality of the heart, and initially there may be sufficient functional reserve to maintain cardiac output at normal values. However, the right ventricle eventually fails to compensate for the hypertension and venous pressure becomes elevated. There is also evidence that the edema associated with chronic obstructive pulmonary disease may be partly due to poor water handling by hypoxic kidneys and may occur without raised atrial pressure, i.e. before pulmonary hypertension has occurred. It is now believed that pulmonary hypoxic vasoconstriction, rather than anatomical damage to the capillary bed, causes the rise in pulmonary artery pressure. Erythrocytosis, occurring as a response to hypoxia and causing a rise in hematocrit, increased resistance to flow and an increase in red cell clumping, can also play a part. As hypoxia is the causative factor, treatment of Mr. LT's respiratory failure is vital. Episodes of frank heart failure frequently appear during infective episodes. Supplementation with oxygen reduces hypoxia, and there is now good evidence that long-term oxygen therapy reduces mortality, morbidity and frequency of hospital admission in such patients. Current guidelines recommend that long-term oxygen therapy, LTOT, is prescribed for patients with chronic obstructive pulmonary disease who, when stable, have a resting PaO2 less than 7.3 kPa, or between 7.3 and 8.0 kPa with at least one of the following: secondary polycythemia, nocturnal hypoxemia, oxygen saturation of arterial blood, SaO2 less than 90% for more than 30% of the time, peripheral edema or evidence of pulmonary hypertension. To obtain the benefits of long-term oxygen therapy, patients should breathe supplemental oxygen for at least 15 hours per day. Mr. LT's oxygen saturations SaO2, as measured by a pulse oximeter, were recorded as 91% before discharge. Oxygen saturations can be used to select patients who require further blood analysis. If the oxygen saturation of arterial blood is greater than 92%, assessment with arterial blood gases is not indicated. If oxygen saturation of arterial blood less than 92% on 2 occasions 2 to 3 weeks apart, referral for a long-term oxygen therapy assessment is indicated. Patients should not be assessed for long-term oxygen therapy during an acute exacerbation of the disease or for 1 month afterwards. Long-term oxygen therapy assessment consists of arterial blood gas analysis on air on 2 separate occasions at least 3 weeks apart. It is important that Mr. LT is assessed again when he is stable before oxygen therapy is started. Diuretic therapy will reduce edema, improve peripheral circulation, and may improve gaseous exchange in the lungs if pulmonary congestion is present. It should be remembered that as Mr. LT recovers from the acute exacerbation of his pulmonary disease, the cor pulmonale is also likely to improve and his diuretic requirement may therefore decrease. The potency of a loop diuretic will be valuable in the acute treatment of Mr. LT's cor pulmonale. In addition, as he had a raised serum potassium on admission, the greater capacity of loop diuretics for lowering potassium levels acutely may be a further advantage. During long-term use, however, thiazides have a greater potential for causing hyperkalemia, and as patients with chronic obstructive pulmonary disease tend to have low total body potassium, a loop diuretic would also appear to be more appropriate as long-term therapy. Furthermore, a potassium-sparing diuretic can be added to the treatment to avoid exacerbation of this problem. Spironolactone has traditionally been used in severe heart failure and is theoretically appropriate, as raised aldosterone levels are frequently present owing to hepatic congestion. Amiloride is a suitable alternative, but before either of these drugs is prescribed, it is important to check that Mr. LT's serum potassium has returned to normal. Whichever diuretics are chosen, it is important that their effect on Mr. LT's electrolyte balance is monitored. Digoxin is thought to be of little value in cor pulmonale unless atrial fibrillation needs to be controlled. Pulmonary vasodilators are theoretically useful additions to therapy, but are not yet of proven value. Hydralazine, calcium channel blockers and angiotensin-converting enzyme inhibitors, abbreviated as ACEIs, are examples. Although angiotensin-converting enzyme inhibitors are first-line therapy in many forms of heart failure, there is no evidence of their benefit in cor pulmonale. This group of drugs is beneficial in patients who have left ventricular failure, which is not the case in cor pulmonale, where left ventricular function is usually not severely impaired. If there is a more complex etiology, such as a history of ischemic heart disease, there may be a place for an angiotensin-converting enzyme inhibitor. On day 40, inpatient day 10, a pre-dose serum theophylline level was reported as 19.6 mg per liter. The reference range is 10 to 20 mg per liter. Mr. LT was noted to have a significant tremor. Question 17 reads, would you recommend any change in his theophylline dosage? The correct response is, yes. Mr. LT's dose of slow-release theophylline should be reduced to 300 mg twice daily, given every 12 hours. The serum theophylline sample was taken on the third day after changing to slow-release tablets, so steady state had been reached. As the level is from a pre-dose or trough sample, it is likely that the peak theophylline concentration is greater than 20 mg per liter. This observation, combined with Mr. LT's continued tremor, which is a side effect associated with high serum theophylline levels, leads to the recommendation for dosage reduction. A suitable dose could be more accurately determined by pharmacokinetic calculation. His serum theophylline level should then be rechecked at his first outpatient appointment, or preferably earlier by his general practitioner. The sample should ideally be taken 8 hours post-dose, giving a mean steady-state concentration for a 12-hourly regimen, but this is unlikely to be practicable in an outpatient setting, and the actual time of sampling must be taken into account when interpreting the result. On day 41, inpatient day 11, Mr. LT's respiratory condition was greatly improved and his ankle swelling had diminished significantly on furosemide. He was discharged on the following medication: furosemide 40 mg once daily in the morning, salbutamol 100 microgram MDI, 2 puffs when required, prednisolone 10 mg once daily in the morning for 7 days, then stop. Tiotropium 18 micrograms daily via a HandiHaler device. Theophylline 300 mg slow-release tablets 1 twice daily. Salbutamol 2.5 mg 4 times daily via a nebulizer PRN. He was given an outpatient appointment for 6 weeks later. Question 18 reads, would there be any advantage in continuing Mr. LT's oral steroid therapy long-term? Would inhaled steroid therapy be more appropriate? The correct response is, no. Indefinite continuation of Mr. LT's systemic corticosteroid therapy would not be appropriate. However, inhaled corticosteroid therapy could be considered. Oral corticosteroids are beneficial in the management of exacerbations of chronic obstructive pulmonary disease. They shorten recovery time, improve lung function, i.e. forced expiratory volume in 1 second, and hypoxemia, i.e. PaO2, and may reduce the risk of early relapse, treatment failure, and duration of hospital stay. However, They have only a limited role in the management of stable chronic obstructive pulmonary disease, and few data suggest which patients, if any, derive benefit from long-term use. Indeed, oral corticosteroids have been shown to increase mortality in patients with advanced disease. However, for some severely affected patients with advanced airflow obstruction, it is difficult to stop oral corticosteroids after an exacerbation, and it might be necessary for patients to continue on them at the lowest possible dose, e.g. prednisolone 2.5 to 5 mg per day, to minimize adverse effects. Abrupt withdrawal of doses of up to 40 mg daily of prednisolone, or equivalent, which have been taken for up to 3 weeks, is unlikely to lead to clinically relevant hypothalamo-pituitary adrenal, abbreviated as HPA, axis suppression in the majority of patients. Therefore, for most patients treated for an exacerbation of chronic obstructive pulmonary disease with prednisolone 30 mg daily for 7 to 14 days, the tablets can be stopped abruptly. There is no need for gradual tapering. Regular treatment with inhaled corticosteroids does not modify the long-term decline of lung function in patients with chronic obstructive pulmonary disease. However, there is good evidence to suggest that it reduces the frequency of exacerbations and thus improves health status for symptomatic chronic obstructive pulmonary disease patients with moderate or severe disease, forced expiratory volume in 1 second less than 50% predicted, who suffer from repeated exacerbations. The role of corticosteroids in milder disease is, however, less clear. Prior to admission, Mr. LT had been prescribed a beclometasone inhaler, but he had not used it for several months because he felt it did not help. This is a common observation by patients with chronic obstructive pulmonary disease and asthma, but is very misleading. On further questioning, it can frequently be established that the patient did not realize that regular, continuous therapy was required for benefit, and that he or she had stopped using it because no immediate relief was obtained on a, when required, basis. As mentioned previously, the dose of inhaled corticosteroid may have been too low, 400 micrograms beclometasone daily, to have a therapeutic effect on his chronic obstructive pulmonary disease. The dose required to achieve a beneficial effect with minimal adverse effects is not known, and more data are needed. Many trials in the treatment of chronic obstructive pulmonary disease have only used maximum daily doses. As a consequence, Mr. LT should be prescribed regular, high-dose inhaled corticosteroid therapy. He certainly fulfills NICE criteria for an inhaled corticosteroid, FEV1 32% with at least 2 exacerbations in the last 12 months. The only formulations of inhaled steroids currently licensed for the treatment of chronic obstructive pulmonary disease are the inhalers that contain both a corticosteroid and a long-acting beta-2 agonist. One of these should be added to Mr. LT's regimen. The choice depends on Mr. LT's inhaler technique and preference, local prescribing guidelines and cost. Question 19 reads, what points would you discuss with Mr. LT when counseling him on his take-home medication? A. Salbutamol. The nebulized therapy is the most complex part of his treatment and must be explained to Mr. LT in detail if he is to continue using it long-term, with emphasis on the importance of using the correct fill volume, cleaning and maintenance. If possible, Mr. LT should be observed using his own equipment. He must understand when he is to use his nebulizer rather than administering salbutamol via his inhaler. Nebulizers are not routinely recommended, as discussed earlier, for the management of stable chronic obstructive pulmonary disease, but some patients may keep one at home to use in the event of an exacerbation. He must also know who to contact if the machine breaks down, and arrange to have it serviced at least annually. B. Regarding prednisolone, confirm that Mr. LT understands that he is to stop taking this drug after 1 week. C. Regarding furosemide, the dose should be taken regularly in the morning and Mr. LT should continue taking these tablets until told otherwise. D. Regarding theophylline, the tablets should be swallowed whole, at regular intervals, and preferably after food with a cold drink. The concept of sustained release should be explained. Mr. LT should realize that this therapy will continue indefinitely, and that he will need occasional blood tests to check that the dose is right for him. He should be aware that a number of other medicines, including some antibiotics, affect the level of theophylline, and he should remind his doctor that he is on theophylline when his treatment is changed. This is also important when buying over-the-counter medicines. E. Regarding tiotropium, the effect of this medicine lasts for 24 hours, so it should be taken just once a day. It may take several days before full benefits occur, and this should be explained to Mr. LT. He should be told about the incidence of it causing a dry mouth, and should be advised to rinse his mouth after using the inhaler to help prevent dryness and relieve throat irritation. It is important to check he can use his inhaler by asking him to demonstrate this to you. The patient information leaflet provided with the medication is useful to help guide your counseling. On day 70, Mr. LT attended the outpatient department. He was reasonably well, able to walk around the house, and dress and wash himself. He was still short of breath on exertion, with some ankle edema and a few rhonchi at both bases. The doctor prescribed a further inhaler containing both a steroid and a long-acting beta-2 agonist, and Mr. LT was advised to use this on a regular basis twice a day. He was warned that he might need antibiotics should he get another chest infection, and the nurse provided him with a self-management plan to guide him should he have another exacerbation of his chronic obstructive pulmonary disease. Question 20 reads, how should Mr. LT be advised on the self-management of his chronic obstructive pulmonary disease? The vital components of a chronic obstructive pulmonary disease self-management plan have yet to be determined, and there is no evidence that asthma self-management plans are helpful. However, the NICE guidelines suggests that self-management or exacerbation action plans look to be promising. The plan should cover the following. A. How to recognize when the chronic obstructive pulmonary disease is getting worse: breathlessness, more sputum, colored sputum, and/or fever. B. How to first increase the use of short-acting bronchodilators, and, if there is no response, when to contact a primary healthcare professional. C. If oral corticosteroid or antibiotic therapy is held in reserve by the patient. 1. When to start oral corticosteroids if there is no improvement after 1 to 2 days with a maximum dose of bronchodilator treatment. 2. When to start antibiotics if sputum becomes discolored and/or increases in volume. 3. When to contact a primary healthcare professional if they are concerned or not responding to treatment. The aim of self-management plans is to prevent exacerbations by promoting lifestyle adaptation and the acquisition of skills to treat exacerbations early so as to reduce hospitalization and morbidity. Patients with chronic illness who participate in self-management have better outcomes, including reduced healthcare costs, than those who do not. This includes people with chronic obstructive pulmonary disease. In patients with chronic obstructive pulmonary disease, most exacerbations evolve over days rather than hours, but even small changes can precipitate a major deterioration in functional status. The traditional approach to exacerbations of moderate to severe chronic obstructive pulmonary disease has been admission to hospital. The concept of self-management plans for patients with chronic obstructive pulmonary disease is derived from their success in asthma management, when they are used to indicate doses and medications to take for maintenance therapy and during exacerbations. Instructions for crises are often also included. Clinical trials are currently ongoing to support the routine use of self-management plans in patients with chronic obstructive pulmonary disease. Question 21 reads, would you recommend that Mr. LT receive continuous antibiotic prophylaxis? If so, which agents would you recommend, and at what dose? The correct response is, no. Prophylactic antibiotics are not recommended for people with stable chronic obstructive pulmonary disease, because of concerns about antibiotic resistance and potential adverse effects. Antibiotics have been given, prophylactically, with the aim of preventing infections and thereby reducing the number of exacerbations. The antibiotics are usually administered daily, particularly in the winter months, although other regimens have been used. The use of prophylactic antibiotics, e.g. routine continuous or intermittent antibiotics, in patients with chronic obstructive pulmonary disease was studied extensively in the 1950s and 1960s. These studies were small, used less effective antibiotics than those available today, and generally showed no benefit. Because of these poor results and the concern about promoting resistance with widespread antibiotic use and the increased incidence of adverse effects, prophylactic antibiotics are not recommended. NICE guidance states that there is insufficient evidence to recommend prophylactic antibiotic therapy in the management of stable chronic obstructive pulmonary disease. In contrast to prophylactic antibiotics, influenza vaccination is clearly effective at reducing influenza as a cause of acute exacerbation of chronic obstructive pulmonary disease. Mr. LT is in the group of patients highly vulnerable to influenza and he should be vaccinated annually. Pneumococcal pneumonia is also a significant risk, and chronic obstructive pulmonary disease patients should receive the pneumococcal vaccine at least once.
Thank you.